This is TTT Live. I'm DK Rostar. The Ministry of Health is giving an update on the status of COVID-19 in Trinidad and Tobago. We're bringing you live coverage on TTT, Talk City 91.1 FM, and on Facebook at TTT Live Online. We go now to that broadcast.
Good morning and welcome to another Ministry of Health virtual media conference, where we provide you with clear, accurate, and up-to-date information on the national COVID-19 response. Our panelists today are Dr. Avery Hines, Technical Director, Epidemiology, Ministry of Health, and Mr. Roshan Siram Singh, Manager, Geographic Information Systems, Epidemiology Unit. I am Al Alexander, Senior Corporate Communications Officer at the Ministry of Health, and I will moderate this morning's media conference. I now invite Dr. Hines to present the latest clinical, vaccination, and epidemiological updates. Dr. Hines.
Thank you, Mr. Alexander. Good morning to my colleague, Mr. Siram Singh. Good morning to the members of the media, members of the viewing and listening public. If we can have the first slide up, please, we'll go through the clinical update. And that update is as at July 25th at 4 p.m. As at that date and time, at both public and private facilities, we would have completed 259,953 COVID-19 tests. Out of those, 37,554 would have returned as positive, and we would have had 30,602 recoveries and 1,039 deaths. And we extend our condolences to the members of those bereaved families. At this point in time, we have 5,913 active positive cases, and those are distributed as follows. There are 314 individuals currently hospitalized, 5,332 persons in home self-isolation, 78 individuals in step-down facilities, and we would have confirmed an additional 189 new positive cases as at yesterday's update, and those cases came from samples that were collected between the periods of July 21st to 24th, 2021. There are currently 127 individuals in state quarantine facilities. Moving on to the vaccination update. At this point in time, as at 4 p.m. yesterday, there were 335,273 individuals who have received at least their first dose, and the total individuals fully vaccinated, meaning having received the first and second dose of a WHO-approved vaccine schedule, numbered at 181,488. So again, what we want to do is to remind all that as we continue to drive this vaccination of the population, and as we continue to have the time roll forward and individuals become fully immunized 2 weeks after their full vaccination, we still need to continue to adhere to those public health guidelines and rules. Even though you've been vaccinated, the entire population needs to follow the same pattern, the same rules, so that we benefit most from the added protection of the vaccine rollout. I'd like to move into the epidemiological updates, if we can have the first slide for that. Apparently these slides don't appear to be working. So what we'll do is we'll just do a quick summary of the epi trend. What we would have seen as at the last update, which I believe was on Wednesday, was that we were having what we called a plateau. And that plateau really refers to the same number of cases day on day over an extended period of time. So whereas previously, from May to June, we had seen that the cases had begun to come down, the heights of the bars in that graphic were beginning to get shorter and shorter. As we moved from June into July, we found that the rate at which that decrease was happening was itself slowing. And coming down towards the last couple of weeks in July, the last maybe 10 to 14 days or so, we've seen that we've hovered around an average, a rolling average, that has remained fairly steady as opposed to continuing to decrease. Now, what this means as we are moving forward is that we are seeing different forces at play. One force is the public health regulations and the vaccination and the other factors that have been put in place to try and reduce the risk of spread. And that force has been driving the numbers of cases downward. The other first, of course, is the fact that we have begun to move around a lot more as a population. We have the construction sector back out, we have the food sector back out, and that in and of itself means a larger volume of movement, interaction between members of the population. As we still have the virus in circulation, as there's still susceptible people, meaning individuals who can catch the virus, we do still need to maintain the utmost precautions as we begin to move around more, because that movement is going to increase the risk of cases and transmission, and therefore of an increase in the overall rate of transmission of the virus. What we've seen over the last 3 weeks is slowly increasing numbers, cumulative numbers from 1 week to the next. I don't know if the slides are ready yet. 1 second. So as we've seen slowly increasing numbers or cumulative numbers between over the last 3 weeks. 1% increase, 5% increase. The last week, between last week and the week before, there was an 8% increase. And what we are cautioning the population of is the fact that as we move around more and we increase the risk of transmission, we need to be even more stringent with the public health, the adherence to the public health recommendations in order to avoid a steep or rapid increase as we move forward. I'm going to turn back over to Mr. Alexander.
Thank you very much, Dr. Hines. At this time, we go for a short commercial break.
When wearing a fabric mask, clean your hands before putting it on. Inspect the mask and do not use it if it is damaged or dirty. Cover your mouth, nose and chin. Adjust the mask to your face, leaving no gaps on the sides. Avoid touching the mask while wearing it. Change your mask once it gets dirty or wet. To take off the mask, clean your hands first. Remove it by the straps behind the head or ears without touching the front of the mask. As you remove the mask, pull it away from your face. Clean your hands after taking off any mask. If you need to reuse a fabric mask, store it in a clean, resealable bag. Hold the mask at the elastic ends when removing it from the bag and make sure it is not dirty or wet before using it again. Wash fabric masks in soap or detergent, preferably with hot water, at least once a day. Make sure you have your own mask and do not share it with others. When wearing a mask, make sure you know how to put it on, use it, remove it, and discard it or wash it correctly. Remember that a mask alone cannot protect you. When wearing a mask, continue to adopt other measures to prevent the spread of the virus. Stay at least 1 meter away from others. Clean your hands frequently and thoroughly, and avoid touching your face and mask. Stay safe, and let's all prevent the spread of COVID-19.
In crisis situations, children can perceive anxiety, which can cause them to feel stressed. Depending on their age, their response may vary. Some may become overly attached, while others may withdraw. Some may become anxious, angry, or agitated, and others may even start wetting the bed. Here are 5 tips to help manage stress in children. Play. Encourage children to play and suggest activities to help them relax. Bond. Try to keep children close to their parents, caregivers, or family members. If separation is necessary due to hospitalization, quarantine, or isolation, try to ensure regular contact via telephone or any other available means. Routine. Establish a daily routine or schedule and stick to it as much as possible, especially in the house. Create a routine in which they can participate in household activities but also provide enough time to play and rest. Talk to them. Explain what's happening and provide clear information on how to reduce the risk of being infected by the disease. Be clear. Use words and phrases that are easily understood and age-appropriate. Calmly explain what could happen if your child or a family member begins feeling unwell. Let them know they may require medical attention or even hospitalization to make sure they recover. Remember, listen to their concerns, show them your support, and be there to reassure them. Bear in mind, this is also a difficult time for them and that they'll need the extra love and attention. For more information, please visit the Pan American Health Organization's website, www.paho.org/coronavirus.
Welcome back. We do apologize for that short break in transmission. At this time, we go to Mr. Roshan Siram Singh, who will update us on the latest trends across the country as it relates to the spread and containment of the virus.
Thank you very much, Mr. Alexander. Thank you very much, Mr. Alexander. Dr. Hines, members of the media, members of the listening and viewing audience, special good morning. Today we move quickly into our first slide as we take a look at the cases from epidemiological weeks 22 and 23. And this is just an updated version of the map which is previously presented. You may recall that at the last GIS update, epidemiological week 23 was in the process of being mapped. So we have here today the completed version of that map. And we see basically the same trend that we have been seeing with cases popping up in high numbers in those areas with a higher number of people, so greater population, greater number of cases. So we see it along the East-West corridor in central Trinidad, where there's Chaguanas and Cuba in those areas, and we see it coming down in south in San Fernando and other areas, as well as the major road networks along which we have population settlements. We move quickly to our next slide, which will be the map of epidemiological weeks 24 and 25, with epidemiological week 24 representing the period the 13th of June to the 19th of June, and epidemiological week 25 representing the period 20th of June to the 26th of June. And again, we see here when compared to the previous map, and we move quickly across to our next map, which will be the same point map of cases recorded during the period epidemiological weeks 26 and 27, with epidemiological week 26 covering the period the 27th of June to the 3rd of July, and epidemiological week 27 covering the period the 4th of July to the 10th of July. And we see here again similar patterns, though the numbers are coming down. If it is we look at the chart to the side, we will see the y-axis. So the counts of cases, you will see the greatest number here in this particular chart is 200. Of course, there's County Carney, which in epidemiological week 26 recorded over 200 cases, but it was still less than those the number of cases recorded during epidemiological weeks 25 and 24. So what we see, a similar trend, a similar pattern, spatially and in terms of numbers, with cases showing preference for those areas of high populations. We quickly move to our graph, in which we summarize the number of cases per county broken down by epidemiological week. And here we cover the period epidemiological weeks 24 to 27, which covers the period 13th of June to the 10th of July. And we see generally in several counties, such as St. Andrew, St. David, St. George East, and St. George West, we are seeing that continuous downward trend. However, in other counties, such as Nariva Mayaro, St. George Central, St. Patrick, Tobago, and even Victoria, we are seeing fluctuations in the numbers of cases. So this would sort of align with that period during which the rate of decrease in cases overall began to slow. So this slowing cases, we are seeing some fluctuations, minor fluctuations, but fluctuations nonetheless. We are not seeing this continuous downward trend in those counties. County Carney generally showed a downward trend with the exception of epidemiological week 25, but we are seeing the number of cases in that county coming down. We take a look at our choropleth map. Again, this is an updated version to the previous choropleth map shared during the last GIS update. This map covers the period epidemiological weeks 22 and 23. So this will be the 30th of May to the 12th of June. Again, it's just an update to the previous map. And during this period, we saw that there were several communities which recorded over 50 cases each. But as we take a look at our next map, which will be representative of the period the 24th and epidemiological weeks 24 and 25, which, in terms of the dates, cover the period the 13th of June to the 26th of June, we see, yes, while a lot of communities, a majority of communities, continue to record at least one case, we see that the number of communities recording over 50 cases, it dropped significantly. We also see that they generally, the counties, in several cases, the communities in the counties began to record less and less cases, and we are seeing that by way of the colors becoming lighter and lighter. We take a look at epidemiological weeks 26 and 27, which covers the period the 27th of June to the 10th of July. And again, we see that downward trend continuing with the lighter colors and fewer communities recording higher numbers of cases. So in this particular map, we see that there was only one community which we could identify which recorded over 40 cases, whereas before we were looking at several communities recording over 50 cases. So generally the numbers are going down. The maps show us visually what the numbers, it shows us that decrease as would have been identified by the numbers. We take a look now at our space-time trend analysis. And what this does is it shows us, it gives us an indication of the trend, be it upward or downward trend over time. However, in this particular map, we look at an output area of a 1 kilometer hexagon, so it's very granular. compared to the previous maps. It's not at the county level. A 1 kilometer hexagon is relatively small. And what we see nationally is that in many cases, we couldn't identify an identifiable trend. We couldn't point to a particular trend, be it upwards or downwards, and that is represented by those white hexagons. However, there were several cases across the country, in most of the counties, where we were able to identify upward trends as represented by the red hexagons and downward trends as represented by the blue hexagons. So nationally, we see that there's a spread in terms of the areas which are recording upward trends as well as downward trends. So we take a look now at County Carney. County Carney, we see generally there are many areas, again, which we could not identify a particular trend, but there are several areas with upward and downward trends scattered across the county. Similarly, as we take a look at County St. George Central, in most of the areas we could not identify a particular upward or downward trend as represented by the white hexagons in this case. However, in 2 areas within that particular county, we saw upward trends, strong upward trends, but in other areas, there were more areas, I should say, representing that downward trend, which is positive, of course. We take a look now at St. George East, and again, similar pattern in that there were many areas in which we could not identify a particular trend, but there were those areas in which we were seeing downward trends, and a few areas scattered across the county in which we were seeing upward trends. Finally, we take a look at County Victoria, and similar to the last map, the last version of the County Victoria space-time trend analysis map, in many areas, no identifiable trend. However, there were several areas across the county with upward trends and downward trends, with a strong upward trend noted in only one of the areas identified in the map, that is just outside the San Fernando Marabel area. But generally, we are seeing a mix of trends within the area. And what we note is that this is directly in line with the fluctuations in cases, which we noted during that particular period. Again, these maps represent epidemiological weeks 24 to 27, and the maps visualize what we see and what we note with the numbers over time. We move finally to our dashboard slide, and I will take the opportunity again to remind everyone, as we move to the next slide, that for credible and reliable information, please feel free to visit the Ministry of Health's website. Of course, there's a GIS dashboard which could be accessed by visiting the Ministry of Health's website at health.gov.tt/COVID-19. With that, I say thank you very much, and I hand over to Mr. Alexander. Thank you.
Thank you very much, Roshan. At this time, we transition to the question and answer segment. We remind our media representatives to state their name, media house, and identify which panelists they wish to pose their questions to. Because our time is limited, we will accommodate a maximum of 2 questions per media house in the first instance. We will take the first questions from 103 FM. Good morning. Good morning.
Hi, morning. You hear me clearly?
Clearly.
All right. Good morning to everyone. My 2 questions would be to Dr. Hines. How many infections in TNT of COVID-19 have we seen in fully vaccinated persons? Not necessarily hospitalizations, but infections in general. And what behaviors, this is my second question, what behaviors do you think are behind that slow increase in numbers that you would have mentioned earlier on this morning? Thank you.
Okay, thank you for the 2 questions. The answer to the first question is difficult because not everyone who has a COVID-19 positive test captured also has their vaccination status captured. So sometimes it's not captured either way, so you're not sure if it's a no, not vaccinated, or we don't know. And therefore, it's difficult to say with any certainty how many people have been fully vaccinated and yet still acquired the COVID-19 infection. That's not something that we really have an easy way of tracking. Nonetheless, what we do want to remind the population of is the fact that the COVID-19 vaccinations that we have, while they do reduce your risk of becoming infected, they don't reduce the risk to 0%. So there is still the possibility that individuals can be infected, albeit a much lower risk. Similarly, the COVID-19 vaccinations that we have reduce the risk of transmission, not all the way to zero, but significantly. And therefore, the more people that we have fully vaccinated, the greater the overall population effect will be in reducing both infections in individuals and transmission onwards. Most importantly, full vaccination has been shown both internationally and locally to reduce the risk of severe outcomes. So while we don't have all of the individuals' vaccination status, even for those hospitalized just yet, but we're working on that, we have noted that among those where there have been fatalities, we've noted that none of those individuals has been fully vaccinated. So we're taking that as a data point in line with the international trend that full vaccination does indeed reduce the risk of fatal outcomes and also of those more severe outcomes. With respect to the behaviors, again, nothing has changed with regard to what increases the risk of transmission of COVID-19. So I know we had some technical difficulties. I don't know if everything that I mentioned in the earlier part of this broadcast was actually captured. So I'm going to repeat. As we move around a little more, as we have more sectors out, both construction and the pickup and delivery of food, meaning not just those workers going out and interacting, but also the population accessing that service, we do have a considerably increased volume of movement and therefore an increased probability of interaction between individuals. And that in and of itself will drive that upward trend, will create that upward force in terms of more cases appearing in the population, and that is working in counter or against the public health regulations and the vaccination strategy. So there's an equilibrium, and we really need to put more force, more effort, more power on the downward force, the downward factors that will drive the infection rate downwards, including vaccination and, of course, including adherence to those public health measures. So there isn't anything special or different. It's just the same thing manifesting itself as behavior and movement patterns change.
Thank you very much, Dr. Hines. We now go to Guardian Media, CNC3. Good morning.
Hi, morning, everyone. Rashad Khan, Guardian Media Limited. Okay, Dr. Hines, so both my questions are to you, and I'd just like to tag on to the questions my colleague would have asked there. Firstly, is it the intention of the Ministry of Health to put systems in place so that we can track the number of breakthrough cases that we would be seeing, and how soon could we see that if that is the case? And my second question pertains to those increasing numbers you would have mentioned a bit earlier. And yes, you did say that people are moving around more and these kind of things. But is it a cause for concern or serious enough of a concern to the Ministry of Health that we're seeing this no longer plateauing trend, but now starting to see that curve somewhat come upwards? And is it a case of we're moving around too much too soon?
Okay, thank you for the two questions. Now, this is where I need to point out something that people may not be aware of. When they track breakthrough cases in a clinical trial setting is very different from a vaccine roll-out setting. We at the Ministry of Health in Trinidad and Tobago are not doing a vaccination trial. We are running a vaccination program. When they do vaccination trials, they follow up with everyone who has been vaccinated to verify outcomes thereafter. They've dedicated a significant amount of resource, etc., to being able to do what they call ascertain those outcomes. That's not the same pattern, it's not the same setting as when you're running a vaccination program. So it's not going to be so much of the ministry's intention to try and track every single breakthrough case in the same manner as a vaccine trial, but we have been requesting that individuals who come for testing have their vaccination status ascertained, so we have some idea of who is vaccinated and who isn't. What we will not have, even with that data collected, would be a denominator to make sense of what that means in terms of the proportion of breakthroughs. So it's not really a data point that's being aggressively pursued, for the simple reason that the resources don't really exist to do that in the same controlled manner as in a trial, and therefore data that comes out of that may be partial and therefore may be skewed and therefore may be misinterpreted. So that's point one. With respect to the movement and the concern, of course, any change or any upward trend in the data, in the number of cases, is a cause for concern. We don't want to be preemptive and say that people are moving around too much too soon, because movement is necessary. However, we do want to encourage every individual to make wise choices about how they move, about where they move, about what they do when they move, about whether they need to move or not. So that as we have more freedom to move around and conduct business, it doesn't automatically equate to meaningless movement. So the extent to which we can reduce our risk of interaction, even as we have more freedom to conduct business and do what we need to do, then that's the extent to which we will help to put a braking force on the increased risk that goes along with increased movement. So not necessarily too much too soon, but definitely a warning bell to the population that we need to still be very careful, very aware of the fact that we're still a susceptible population, and therefore we can't operate as life as usual when we start to move around again. Not just yet.
And Dr. Hines, I'm sure that the 3 Ws would be best used at this time?
And yes, and as we have been stating, and thank you for the reminder, the 3 Ws are the summary of those public health regulations. We want to continue to wash our hands as we move from place to place. We want to continue to watch our distance, especially when we are accessing a service. Trinidadians seem to have the tendency to get into each other's personal bubbles a bit. We get really close in lines. We sometimes less than an arm's length away. 6 feet is 2 arms lengths. So just gauging, if you can reach out and touch the person in front of you or behind you, you're too close. You're not watching your distance. And of course, the wearing of the masks, which is mandatory at this point in time, continues to be a very key component of that strategy.
Thank you very much, Dr. Hines. We now go to TTT.
Hi, good morning, everyone. Sonolala, TTT News. Mr. Siramsing, I know you would have indicated that some areas would have seen some sort of fluctuation in terms of COVID cases. Could possibly one of those be vaccine hesitancy in some of these areas, or on some areas not getting as much vaccines as possible at this point in time? And any update as well on Miss C cases? What are we seeing in terms of that? I know it would have been probably a while we have not an update. Any update on that?
Okay, thank you, Mr. Lala. I'll actually take both of those questions. Now, the vaccine distribution, we're still actually compiling the data on the overall geographic distribution of the vaccine uptake, but it has been quite uniform in respect of where the sites have been, and good uptake at each site, very active access to the vaccines as they're being rolled out. So the issue of hesitancy doesn't really arise. We are seeing a great degree of vaccine acceptance, and we want to continue to encourage the population to access the vaccines as soon as they become available, and they are more available now. So now is the time to get, as we said, get ahead of any upward trend by making yourself and therefore the population less susceptible. So at this point in time, it would be premature, especially as we are still at the early-ish stages of the vaccine rollout of vaccine program, to link the trends that we're seeing in geographic areas to vaccine uptake in those geographic areas. It's not a link that we can make yet. We're going to continue to analyze the data, and maybe later we'll be able to make more statements along those lines. And with respect to Miss C, again, what we do each time we have to comment on that particular phenomenon, we bring the specialists back because they have the detailed data which they can share. So we can schedule another update on that in one of the upcoming conferences.
We certainly will do that. We now move to AZP News. We're ready for your questions.
Good morning, Private Harry, AZPnews.com. My both questions are for Dr. Hines. And Dr. Hines, I just wanted to put on record that the last time you were at the presser, I'd alluded to the number of deaths in Trinidad and Tobago, and I just wanted because of COVID-19, and I just wanted to say that my line of questioning was neither meant to be sensational nor nor reckless, right? What I was trying to find out was to compare the case fatality ratio of Trinidad and Tobago to that of the case fatality ratio of the rest of the world, and how the case fatality ratio is derived is by taking the number of COVID-19 deaths over the total number of positive cases of that country and multiplying it by 100. So therefore, Trinidad and Tobago, as of yesterday's figures, has a case fatality ratio of 2.77, whereas the case fatality ratio of the rest of the world is 2.14. Hence, Trinidad and Tobago has a higher case fatality ratio than the rest of the world. So I just want to find out if that is correct. My first question. And my second question is that for the year so far, we have had 908 deaths due to COVID-19, which is an average of 4.3 deaths due to COVID-19 per day. So I want to find out what specific measures is the Ministry of Health using to try and curb these COVID-19 deaths in Trinidad and Tobago. Thank you very much.
Okay, thank you for the two questions, and thank you for allowing me to clarify. So the calculation that you've done and the comparison that you've made are two different things. The calculation is fine, total number of deaths over total number of cases, but when you get the average case fatality rate for the rest of the world, the global average, that in and of itself doesn't mean that all the other countries in the world are at that figure. And that's the point that we made at the last presser, where we indicated that there are countries have case fatality ratios also above that 2.17. In fact, when we checked, Italy was at 2.99, Germany was somewhere around 2.4 something. And these are really, as we said before, reflective of whether a vulnerable population with a higher risk of death is being affected or not. So when you see the global rate, it does not equate to every other country is at that rate. The global rate is an average meaning that there will be some countries that are above and some countries that are below that global average. There are countries with case fatality ratios in the teens, as in more than 10. There are countries with case fatality ratios around 1. And all of these different figures then contribute to that average. So you can't say that the cases or the case fatality ratio in Trinidad is higher than the rest of the world. You can say that it's higher than the global average, but there are other countries that have figures higher than the global average and some that have figures below. So I just want to clarify with respect to your comparison, what comparison you can and cannot make. Now, the second question, again, a good question, because it helps us to make a link to what we think we're doing and communicating that may not be coming out that clearly. When we speak about the public health measures, when we speak about vaccination, when we speak about the avoidance of contact, and we speak about the global or the international travel regulations that help us to reduce risk of importation, all of these are the things that we're putting in place to avoid both new cases and deaths. At the clinical level, you can rest assured that every single individual that is hospitalized receives the best possible care according to the resources that are available, and that care is provided across the board with the objective of having everyone leave the hospital alive. In a global pandemic, that's never going to be the outcome. There will be a proportion of individuals who pass on. We've identified what the risk factors are. We've identified that what we've been seeing is that those who have fatal outcomes have had them in those higher risk categories. And we have identified that one very key strategy is to ensure vaccination of the vulnerable, of those at higher risk, to reduce the risk of fatal outcomes. So, to make the point, if it wasn't clear before, that vaccination strategy is one of the very key components of reducing the death rate, along with the clinical care that has been provided and that resources have been allocated to ensure that we can provide the best possible care for everyone who enters the clinical system. So I hope that does clarify.
Thank you very much, Dr. Hines and Mr. Bihari, for those questions. We quickly move to the Express.
Hi, good morning, everyone. Kimry Fletcher from Trinidad Express. My two questions this morning would be for Dr. Hines. Dr. Hines, there was a recent study by two Hungarian researchers, I believe, that suggests that the Sinopharm vaccines seem to be providing less protection in the elderly population as compared to younger persons. So the research showed that persons who were fully vaccinated, those elderly persons, had a poor antibody response. So seeing that persons in the elderly population in Trinidad have been deemed high risk and been prioritized to be vaccinated, what's the ministry's view on this? And has any observations been made locally in fully vaccinated persons to show a link between the results of this research thus far? So that's my first question. And my second question, now it's been said countless times that any vaccine, not just Sinopharm, does not give 100% protection against the virus. And it's being recommended that we still follow the 3 Ws. However, this is a question from the public that we've seen time and time again. So we just like some clarity. As the number of persons who are being vaccinated increases, do you think that there would be a change in the mask mandate? For example, persons are asking if families are fully vaccinated, why do they still have to wear a mask in their vehicles if at home they don't have to wear a mask amongst each other? That's my second question. Thank you.
Okay, so first question, I'll give the short versions of the responses. In general, what you find is that elderly individuals mount sometimes a less robust immune response to any form of vaccination, whether Sinopharm or otherwise, just as a consequence of the function of the immune system declining a bit as you get older. Now, this does not equate to the vaccine then being less effective. It is just an observation that elderly individuals may in fact have less of that countable or quantifiable immune response in terms of antibody levels, etc. But there's still that level of protection afforded by the vaccination, and therefore the recommendation stands and remains valid that the vaccination in the elderly population does in fact reduce risk, because globally, outside of whatever single study may be reporting on immune response levels, globally what you're seeing is a decrease in death rate across the population, and especially among those vulnerable populations in countries where there's been widespread vaccination. So we are seeing globally that evidence that the vaccinations, including Sinopharm, have been working to reduce that outcome that we most want to avoid, that outcome of deaths. Second question. Again, good question. The tendency to want to revert to what we consider to be normal lingers, although at this point it is way too early to think about moving away from some of the risk reduction measures that have been proven to work well. Even as individuals are vaccinated, the ability to become infected still remains. You may shed less virus even though you're infected, and therefore your masks are an even better form of protection because now they have less work to do to filter out viral particles. There's a smaller burden leaving you as an individual, and your masks are going to help to reduce that even further. So the masks still remain an important layer, no pun intended, of protection for the people around you. So that mask mandate is unlikely to change in the near future because it's still a key pillar of reducing risk at a population level in a situation where we still can get infected, although less likely, and in a situation where there's still the risk of additional introduction of other forms or other variants which are more transmissible. So you don't want to take away a layer of protection while there is still a risk of having a more transmissible variant become part of your circulating viral population. So right now, the masks are going to be a key pillar, and there isn't an immediate consideration on the table, or even a proximal one, of changing that mask mandate at this point in time.
Thank you very much, Dr. Hines. We now go to Newsday for your first two questions.
Good morning to the panel. My two questions are for Dr. Hines. The first one is how many vaccines have been given to private hospitals thus far, and what has the uptake been like? And the second question is, how close is the ministry to having enough data on the number of deaths from the HDU and ICU to be released to the public? Because we've asked about this before and we keep being told that the data is being collected.
Okay, thanks for your two questions. I do not have with me the number of vaccines delivered to the private hospitals in particular. We know that there has been the ongoing public-private partnership where vaccine distribution has been concerned, and that has contributed to the very quick increase in the numbers of vaccinated individuals that we've seen over the past couple of weeks. Breaking it down further into hospitals, not something that I have at my disposal, but that is information that I suppose can be sourced and provided. Again, with respect to HDU and ICU, that is the information that is being compiled, and the issue is really that because the systems for capturing individual level data aren't systems designed to collate that and transmit it, you need to make sure that we have all of the information and that we fill in gaps before we can put that into the public domain. So it's a matter of being very careful to have correct and complete information, but it's something that's being worked on, and as soon as that it reaches a state of completion, that's information that we'll be able to share.
Thank you very much, Dr. Hines. We quickly move to Tobago Channel 5. Good morning.
Hi, good morning. Candice Jackson from Tobago Channel 5 News. My questions are, was there a team that came to Tobago last week to see what's
Candice,
been going on?
could you raise your volume a bit? It's very difficult to hear you. Could you raise your volume,
Hello?
please?
Can you hear me now?
Slightly better.
Hello? Okay. Good morning again, Candice Jackson from Tobago Channel 5. Could you tell me if there was a team that came from the Ministry of Health to Tobago last week to see what's been going on the island with the rise in cases? And secondly, could you share with us the details of that? And secondly, could you tell us what do you think right now about the fact that there are 336 cases on the island, which is some of the highest records that we've had so far since the start of the pandemic?
Okay, thank you for the question. With regard to interactions between the Ministry of Health and the TRHA/THA, those questions are best directed actually to the THA. Now, the question of what you think about the number of cases, again, we need to emphasize to the general population that this is a virus that operates in a particular way. Across the world, we've seen that there have been surges and decreases in viral transmission in various populations at various points in time. So the fact that there is an increase at a given point in time isn't in and of itself a surprise or a cause for query. The management of the surge, the implementation of the public health measures, the containment of the cases, the management of the severe ones, those are the things that you look at, and those, so far as we have been able to tell, have gone according to standard. So there isn't a special or separate concern, even in the face of the expected periodic rises in cases in that segment of the population. So I'm hoping that's a helpful context.
Thank you very much, Dr. Hines. We now go to TV6. TV6, we're ready for your questions.
Good morning, Urvashi from TV6. Dr. Hines, just a quick question, two quick questions. What makes the Delta variant more transmissible? And if you could also, when you go into that explanation, if you could talk about fleeting transmissions as well, and what that now means for measures. Are there measures that we should take a little more seriously or do more? And could you also explain why the Delta variant affects children more? Thank you.
Okay, thank you for those questions. Now, I think the middle question is probably the most important one in terms of what needs to be done more or less. If and when a virus is determined to be more transmissible, the issue of how the virus is transmitted then gives you an indication of what you need to do to reduce that risk. And the way in which the virus is transmitted hasn't changed. the levels of viral replication within cells, and therefore what we call your viral load, is one of the factors that makes that Delta variant more transmissible, because you have more virus in your system, in the back of your throat and the respiratory tract to be shed. So you have more viral particles coming out of an infected person's body and possibly being transmitted to another individual. So those higher levels of viral replication in cells are one of the main factors that are responsible for that increased transmissibility, along with factors that are related to the actual interactions between the spike proteins and the receptor cell, receptors on our cell surfaces. So those two things together make it easier for the virus to get from one individual to the next. And in so doing, it also makes it easier to get to individuals of different age groups. Now, one of the things that we did find was that the absence or the lower levels of certain kinds of receptors in pediatric patients made the infection of certain tissues, those respiratory tissues at the back of your throat, a little less likely. It didn't mean that children weren't able to get it, even that it was difficult for children to get it, but it meant that different manifestations, you got different kinds of symptoms from kids when they got ill, and some of them weren't necessarily respiratory. You're seeing more of the respiratory sort of presentation now among even the pediatric population with this particular virus. And again, the measures for prevention remain the same. The mask wearing of utmost importance, the vaccination of utmost importance. These are the measures that we really needed to, as you said, do more of to ensure that we can protect the population and reduce the risk of transmission of even this more transmissible variant. The greater the level of vaccine protection we have, the greater the additional layer of protection that we employ by having appropriate mask use, by having appropriate physical distancing, by not overloading indoor spaces. And this is the point that I wanted to make, and something I noticed a few times driving along the road. We're seeing where public transport, they're proceeding along the road with the AC on and the windows closed. The only AC that we need right now is air circulation. The windows need to be open so that you reduce the risk of contamination within those vehicles. So again, not crowding spaces, having good air circulation, these are the things that we're going to need to do more of in order to reduce the risk of even the Delta variant becoming an issue.
Thank you very much, Dr. Hines. AC, air circulation. I will keep a note of that. We now go to, this will be our last reporter. We now go to Power 102.
Good morning, Sparkle McIntosh, Power 102 Digital. My question is for Dr. Hines. Just last week, Friday to be exact, CMO Dr. Paris Ram, while addressing the business chamber at Napa, stated that it's just a matter of time before the Delta variant arrives in Trinidad. My question is, are there any perceived vulnerabilities in COVID-19 protocols at the airport, which is the primary port of entry at this time?
Thank you for your question.
Okay. So the protocols that exist for the entire system of bringing individuals into the country include the reduction of risk by the acquisition of a negative PCR test even before you get in. And then subsequent to that, also verifying that you are a lower risk individual by confirming that you have the vaccination for COVID-19 on board. Now, what we've seen in the repatriation exercises that have been ongoing for over a year is that when that additional requirement for the 72-hour PCR came on, we went from having percentages of 6 to 10% sometimes of individuals being positive or turning up positive a week later from coming into the country. We saw that drop to 1% or less, and that is probably the best layer of protection that we can afford ourselves between the reducing the risk of the individual and then confirming the absence of COVID-19 in individual travelers as they get onto planes. There aren't any other perceived vulnerabilities within the travel system at this point in time, but what we do And what we have been doing is we've been continuing to liaise with the relevant authorities in respect of ensuring that all the relevant protocols are being followed. Once those are being followed in conjunction with the risk reduction that we just described, that's about as good a layer of protection as we can provide while still allowing people the ability to move via air travel.
Thank you very much, Dr. Hines. Ladies and gentlemen, we have come to the end of today's media conference. We once again thank the media for their engaging questions and you, our viewing and listening public, for sharing your time with us. Please note that the vaccination rollout continues in all RHAs, and as the COVID-19 restrictions are continuing to be eased, we want to remind you to remain vigilant. Adhere to the COVID-19 health protocols to protect yourself and others. Wash your hands, watch your distance, and wear your mask. As we close, we invite you to view another leader in our series of Voices for Vaccination, Dharmacharya Pundit Dr. Ramprasad Parashram. And also, we have a very interesting video from the WHO that speaks to the efficacy of vaccines, especially against the Delta variant. So I invite you to stay on and view those two videos. Ladies and gentlemen, have a good day, everyone. Stay safe, and let's do our part. Let's vaccinate TNT.
Greetings, Jai Sitaram. Let us pray. Hari Om Sri Ganeshaya Namaha Sri Saraswate Namaha Sri Gurubhyo Namaha Om Shanti 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 Hari Om. God bless you all. You are very dear to us, and your health is of paramount importance. But as you and I know, in the last year and a half or so, we have been seriously challenged by COVID-19. In spite of our best efforts, we have not yet been able to fully defeat this pandemic. So here is what. We now have a golden opportunity to finally defeat it. That opportunity is the opportunity to get vaccinated. I got vaccinated. And I encourage all of you to get vaccinated for your sake, for the sake of your loved ones, for the sake of your community, and for the sake of the society. Yes, there are side effects. When I got vaccinated, I did experience mild fever and some body pains. But when you consider the great benefits that we can get from getting vaccinated, the benefits far outweigh the side effects. So let us do this. Let's get all of Trinidad and Tobago vaccinated. Let us all do this together. Let's vaccinate TNT.
Hello and welcome to Science in 5. I'm Vismita Gupta Smith. We are talking today and vaccines. Dr.